Welcome. In this video, we'll explore evidence-based practice, a paradigm that took shape in medicine and now informs psychology, spiritual care, and other helping professions. In evidence-based medicine, evidence is meant to do more than decorate an argument. It helps us get closer to the truth about what actually works. It also serves as a neutral way to weigh competing claims, so decisions are shaped less by authority or habit and more by what can be shown. That idea is central in Joel Begovic's account of evidence-based medicine, where evidence becomes a disciplined guide for practice, not just opinion dressed up as certainty. A classic definition comes from David Sackett, who described evidence-based practice as the conscientious, explicit, and judicious use of current best evidence in making decisions about care. Conscientious means we don't act casually. Explicit means we make our reasoning visible. Judicious means we apply evidence with care, not mechanically. So evidence-based practice is not blind rule following. It's a disciplined way of deciding, where evidence, judgment, and context all matter. A helpful image is the three-legged stool of evidence-based practice. One leg is empirical research, one is practitioner wisdom, and one is client or patient values. If one leg is missing, the whole approach becomes unstable. In spiritual care especially, client-centered practice means the person's beliefs, hopes, and lived meaning can't be treated as an afterthought. And that raises an important question. We can operationalize research fairly easily, but how do we operationalize wisdom without flattening the human encounter it depends on? The process usually moves through 5 steps. Ask a focused question, acquire the best available evidence, and appraise what you find for quality and relevance. Then comes the hard part. You apply that evidence in the real situation where patient needs, setting, timing, and professional judgment rarely line up neatly. The cycle ends with evaluation. We look at what happened, learn from the outcome, and keep improving rather than treating any decision as the final word. Historically, the movement is often linked to McMaster University in medicine, where Gordon Guyatt helped name and shape evidence-based medicine as a practical framework. In psychology, the emphasis grew around outcomes, effectiveness, and the careful evaluation of which treatments help which kinds of clients. In spiritual care, scholars such as O'Connor and Fitchett helped extend the conversation, asking how research can inform care without reducing spirituality to a narrow clinical variable. Evidence-based spiritual care means using the best available scientific evidence about spirituality, religion, health, and well-being to inform care decisions. That does not mean replacing prayer, ritual, sacred texts, meditation, or pastoral presence with a spreadsheet. It means letting research inform when, why, and for whom certain approaches may help. The goal is wiser practice, not less spiritual practice. Evidence helps guide care while preserving the depth and integrity of spiritual traditions. Across disciplines, evidence-based practice matters because it supports more consistent and effective care instead of leaving major decisions entirely to individual preference. For spiritual care, evidence can also strengthen professional legitimacy, helping chaplains show their value within interdisciplinary teams that often speak the language of outcomes. In practice, spiritual interventions can begin with assessment and consultation, where a clinician or chaplain listens for spiritual concerns, resources, conflicts, and needs. They can also include forgiveness work, contemplative prayer, spiritual imagery, meaning-centered conversation, and other practices shaped by the person's tradition and situation. What makes this evidence-based is not that every intervention becomes identical. It's that we ask whether these practices are linked to outcomes we can observe, such as distress, coping, or well-being. Medicine often gives special weight to randomized controlled trials and systematic reviews because those methods are designed to reduce bias and test interventions rigorously. Psychology also values outcomes research and structured evaluation, though it has developed more treatment manuals and clearer categories for many interventions than spiritual care has. Spiritual care has also adopted an evidence-based approach. Manuals are becoming more common, however, because of the diversity of religious traditions and understandings of care. Some of the most important dimensions of care do not need standardization. Evidence-based practice has never been free of criticism. One concern is that the very idea of good evidence can carry theoretical bias, privileging some ways of knowing over others. Another concern is manualization. Standardization can improve consistency, but many practitioners worry that rigid protocols flatten relationship, nuance, and responsiveness. And there is a deeper tension running through all three fields. How do we apply generalized findings to one singular person in front of us, whose story never fully matches the average case? The ethical question at the center of evidence-based spiritual care is not whether evidence matters. It's how we use evidence without silencing conscience, wisdom, tradition, or the patient's own values. At its best, evidence-based practice holds the balance. Empirical research, clinical wisdom, and patient values working together to support care that is both accountable and humane. As you continue studying or practicing, that's the challenge to carry forward. Not choosing one leg of the stool, but learning how to hold all three in tension.